start. So good morning, everybody, and welcome back to Journal Club. It's a great pleasure to have all of you joining us from all around Europe. It's my great pleasure to introduce Evelina Toscano from Monza in Italy, who will be presenting this paper, which is published in Circulation Intervention, about TAVI in horizontal aorta. And as expert, we're joined by Federico Di Marco from San Donato Clinic in Milano, and looking very much forward to the discussion. Just before we get started, the poll, which is your preferred type of transcatheter valve for patients with a horizontal aorta. Give a few more seconds for people to respond. And interestingly, the results are mainly self-expandable valves with a couple of people for balloon expandable. So I think that'll be an interesting discussion that we can have. So Evelina, over to you.
Okay, so welcome everybody to this Journal Club. Thank you very much for joining. I want just to take just 2 minutes to say that Journal Club is one of the several initiatives that we have in GISA Young. So I would like to remind anyone that you can subscribe to the GISA Society, and this invite also applies to the residents in cardiology. If you are at 4th year of your cardiology school, you can join the society. So I'm from the GISA Young board, and we have so many initiatives that are going on and will be going on in a few months. So let's get connected. And also, Journal Club wants to be interactive. So if you want to present a paper, if you have an idea about a specific topic that we should discuss, or if you want to connect with a senior expert that maybe you admire, and you want to use this occasion to do that, please feel free to connect with us. We have the Instagram account, we have the Twitter account, we have the email, and also there is the YouTube channel in which you can find the records from prior meetings. So I'll start with my presentation. Just a second. Can you see my slides?
Yes, perfect.
Okay, so this is the paper that I'm going to report, Horizontal Aorta in Transcatheter Self-Expanding Valve. This paper was published in Circulation Cardiovascular Intervention a few months ago, and it reports the data from Muticentre experience in performing TAVI with new generation self-expandable valve in patients with horizontal aorta. So for today's meeting, I try to give just a few slides about the topic of horizontal aorta and aortic angle, what it means to perform TAVI in patients with horizontal aorta, if there is a difference between self and balloon expandable valves in horizontal aorta, and first and second generation self-expandable valves. Then we read together the methods, results, and the conclusions of the paper, and then I introduce the discussion with my questions for the experts and the authors and the audience as well. So, what is the aortic angle? The aortic angle is the angle between the plane of the vertebral basal ring and the horizontal plane. Usually, this measure is performed through the analysis of the pre-procedural CT scan. Nowadays, almost every patient that is scheduled for TAVI undergoes a CT scan, pre-procedural CT scan, and any software can easily measure this value. There is not a specific value for aortic angle to define the horizontal aorta, but the more the angle moves towards the 90 degrees, so the more vertical is the vertebral basal ring, the more horizontal is the aorta. Instead, for lower degrees of aortic angle, we have a more vertical aorta. And horizontal aorta is not per se a problem for the patient, but might be trickier for the TAVI operator to perform the TAVI. It might be more challenging because it is harder to orientate and make the valve coaxial with the vertebral basal ring. It might be harder to reach the middle of the aortic cortex instead of the side. And sometimes you might end up being with different implantation depth for each cusp. For example, you might be too low on one side and too high on one side, thus potentially increasing the risk of conduction disturbances of paravalvular regurgitation. And we have some evidence that horizontal aorta is associated with suboptimal procedural results in case of first generation self-expandable valves. And this data come from real practice, because in clinical trials with self-expandable valves, the horizontal plane with an angle above 70 degrees was considered an exclusion criteria. So the most robust body of evidence started to come up since 2016. This is the experience from one single center that reported data from over 500 TAVI patients treated with both balloon and self-expandable valves. They authors analyzed the aortic angle at pre-procedural CT scan, and they identified a cutoff value of 48 degrees to define the horizontal aorta. So in patients treated with balloon expandable valve, there was no difference in device success between horizontal aorta and non-horizontal aorta. Instead, patients that received valve, so first generations of expandable valve, there was a lower device success rate, an increased rate of post-dilation, need for second valve, increased fluoroscopy time, increased valve embolization, and increased paravalvular regurgitation. But, however, there were no differences in terms of mortality at 30 days and 6 months. But authors in this case identified the potential two elements that were favorable in case of horizontal aorta from the balloon expandable platform: the shorter stent frame and the delivery system that is flexible, actively controlled by the operator. But there was also conflicting evidence, because in 2016 was also published the data from Corvalvo at clinical trials, over 3,000 patients treated in 45 clinical sites in the US. All these patients received the measurement of the aortic angle, and the population was divided in 7 subtypes according to aortic angle. And authors did not identify a specific correlation between the aortic angle and the different rates of device success. So this is the first conflicting evidence. And then we have experience with second generation data, but before second generation valves, but before the horse registry, we had mostly experience from single centers. This is the experience from San Raffaele in Milano, in which they collected data from over 500 TAVI patients that received the second generation TAVI, both balloon and non-balloon expandable. And they analyzed the aortic angle at pre-procedural CT scan, defining the horizontal aorta with a cutoff value of 48 degrees. So in the overall population, there was no correlation between horizontal aorta and different rates of device success, pacemaker implantation, or procedural PVR, but just an increased radiation dose and fluoroscopy time. And same for TAVI platform, because in both balloon expandable and non-balloon expandable valves, the horizontal aorta was not correlated with different device success rates, as well as mortality or PVL. And this is the experience from San Donato, in which they studied patients, over 300 patients treated with Portico, Evolut, and Accurate valve. They identified the cutoff value for our horizontal aorta in case of aortic angle above 57 degrees, that was the 75th percentile. And actually, they identified that in patients treated with Evolut valve, the horizontal aorta was associated with higher rates of paravalvular regurgitation. And actually, the aortic angle was an independent predictor of paravalvular regurgitation, but only in the Evolut population and not in the Accurate or Portico. So this is the background of the paper. We know that new generation valves have, in general, better outcome compared with first generation valves, but we did not have enough data about the topic of horizontal aorta and performance of self-expandable valves. So authors focused on these two platforms, the Evolut R Pro system and the Accurate Neo. The Evolut is a self-expanding valve with supraannular design. It has a 16 French, the delivery system has a 16 French outer diameter that corresponds to a 14 French sheath. It is recapturable and repositionable, and it's available in 4 sizes. The Accurate is still a self-expanding valve with supraannular design, but the structure of the Accurate is different than the Evolut, because it is composed of 3 stabilization arches, then the commissure pot, the upper crown, and the lower crown. These arches are, we can say, developed in order to help self-align the valve with the native annulus. Then the upper crown is the structure that anchors to the in supraannular position. And then it also has a different deployment system than the core valve, because the core valve usually opens from the bottom, normally opens from the bottom to the top. Instead, the Accurate has a top-down deployment, but it's not repositionable or recapturable, and is available in 3 sizes. So the HORSE study is a Muticentre international retrospective registry collecting data from 16 centers in Europe and Canada 3,862 patients treated with transfemoral TAVI using the Evolut platform or the Accurate Neo platform. Exclusion criteria were TAVI for aortic regurgitation, surgical prosthesis degeneration, and non-transfemoral access. And since there is not a comparable size in the Accurate for the 34 millimeters, these platforms were excluded. Any patients they collected data from clinical characteristics, echocardiographic characteristics, and also data from the pre-procedural CT scan. And they retrospectively analyzed from the CT scan the aortic angle that was the angle between the virtual basal ring and the horizontal plane in a coronal projection. Outcomes were defined according to WASP criteria. Primary endpoint was device success. As usual, that is the absence of procedural mortality and correct positioning of a single prosthetic valve in proper position without moderate severe paravalvular regurgitation and increased gradient. The aims of the study were to identify the impact of horizontal aorta on study outcomes, and then among patients with horizontal aorta to compare the performance of the Evolut and the Accurate device. So these are the analyses that they performed. They compared the baseline characteristics. They performed a ROC curve analysis in order to identify the best cutoff value to predict device success, logistic regression analysis, sensitivity analysis, and then finally to compare the Evolut and Accurate in patients with horizontal and non-horizontal aorta. They performed inverse probability weighting to adjust for baseline characteristics. So this is the population. These are raw data of baseline characteristics of the population. We have, of course, a different population in the Evolut and Accurate because there is a difference in age, there is a difference in BMI, COPD, prior MI, prior PCI, and also in peripheral vascular disease. We know that the Evolut has a lower profile device, so delivery system. So it was more common, the peripheral vascular disease in the Evolut population. Also, there was a difference in STS mortality score that was higher in the Evolut population compared to the Accurate. These are the non-hospital outcomes. So overall, there is a very high device success rate, almost 90% in every group in the overall population, in the Evolut and the Accurate. But in the Accurate group, there was a lower contrast volume, fluoroscopy time, and radiation dose. The valve embolization was similar, as well as need for second valve, and the rate of stroke was a little bit higher in the Accurate population compared to the Evolut population. And then the rate of new onset left bundle branch block was higher in the Evolut, as well as the rate of new pacemaker. Instead, the paravalvular regurgitation was higher in the Accurate population. In-hospital mortality, however, was comparable between the two groups, with a difference in cardiovascular mortality. Authors performed a multivariate analysis in order to identify independent predictors of device success for the overall population. And aortic angle and device type were not associated with differences in device success, but other baseline characteristics were identified. But when analyzing only the population receiving the Evolut platform, the aortic angle resulted as an independent predictor of device success. So the higher the aortic angle, the lower the device success rate. That was not evident in the Accurate population. The aortic angle was not an independent predictor of device success, but they identified atrial fibrillation and post-dilation. This is the ROC curve analysis that identified the cutoff value for horizontal aorta at 49 degrees. Of course, the population in the with horizontal aorta and non-horizontal aorta had several differences in baseline characteristics. These are the data in the population divided by device type: Evolut and Accurate, horizontal aorta, non-horizontal aorta. We can see that in the Evolut group, the device success was different, was higher in the normal aorta compared to horizontal aorta, and also the rate of paravalvular regurgitation. There was a difference in the procedural death. There was also a statistically significant difference in left bundle branch block, new onset atrial fibrillation, and permanent pacemaker. Instead, in-hospital mortality was the same for horizontal aorta and non-horizontal aorta. When analyzing data in the Accurate population, we have increased radiation dose in case of horizontal aorta, but device success and paravalvular regurgitation were comparable between horizontal aorta and non-horizontal aorta, and as well was in hospital mortality and the other outcomes like permanent pacemaker, new onset BBB, and atrial fibrillation. So this is the graphic representation of same results. So in patients that received the Evolut platform, there was a higher rate of device failure and a higher rate of permanent pacemaker that was not reported in patients receiving accurate platform. And this is the plotted data. These are the plotted data of aortic angle correlated with device success. We can see that for the Evolut, the higher the aortic angulation, the lower the device success rate. That is not evident for the accurate NEO population. And finally, authors compare Evolut and accurate platform in patients with non-horizontal aorta and horizontal aorta with the EPV, so inverse probability weighting, in which they adjust for baseline characteristics the performance of the Evolut compared to the accurate. So in patients with non-horizontal aorta, device success was not related to device type. Instead, in patients with horizontal aorta, the device success was better for patients that received the accurate platform. There was a difference in procedural death and a difference in permanent pacemaker, because both in non-horizontal aorta and in horizontal aorta, the Evolut was associated with higher implantation rate of implantation of pacemaker, but lower rates of PVL just in case of non-horizontal aorta. That was not confirmed in the horizontal aorta group. Major vascular complications were different both in the non-horizontal aorta and horizontal aorta group. This data means that they were lower in the Evolut platform compared to the accurate. So authors conclude that horizontal aorta defined by an angulation above 39 degrees is very common among the patients, unselected patients undergoing TAVI. Horizontal aorta independently predicts device failure for Evolut, but not for accurate valve. And Evolut platform is associated with lower device success in case of horizontal aorta that was not evident with accurate valve. So, of course, the paper has several limitations. First of all, the nature of the paper, because it is a retrospective analysis of a Muticentre registry, there is not randomization between device selection. But these are interesting data, and this is the first comparison of the two devices regarding the horizontal aorta, because we know that there is a comparison, a propensity match analysis, and also randomized study comparing the Evolut with the accurate, but none of these two studies analyze the impact of horizontal aorta on TAVI performance. And so, according to this, I finish my presentation. I will give you just a few questions in order to introduce the discussion. First of all, is this evidence strong enough to have a clinical relevancy in device selection for transfemoral TAVI? Or if not, how would you increase the body of evidence other than randomized trials? The second question is, among unmeasured confounders, how much operators' experience in TAVI might have an impact on the results? Because we have seen that in casuistics coming from large single centers, from high volume single centers, actually they had a similar device success rates with both horizontal and non-horizontal aorta. And then we have newer generation valves like the accurate NEO2, the Evolut Pro Plus. So how can you imagine the performance of these devices in horizontal aorta? And finally, since I know that Federico, you are an expert also in the topic of commissure alignment, I would ask you, is it harder, trickier to align the commissure in case of horizontal aorta? So I just finished. Thank you very much.
Thank you very much, Evelina. Great presentation, a lot of points. I think you went through a really nice review of the literature. We have studies showing an impact, studies which do not show an impact. So it's kind of really. I think the first question is really important. I mean, this study is probably the one you presented. The horse registry is probably the largest one. So maybe it has some ability to kind of account for confounding variables, which when we take into account just a single feature as horizontal aorta is, maybe are quite a lot. So we have the impact of, tortuosity. Horizontal aorta obviously comes with a higher tortuosity, the impact of an acute aortic angle in the aortic arch, which is somehow often associated with the horizontal aorta, but we don't have a measure of how these single variables do impact on the technical requirements needed to implant a TAVI device in a patient with a horizontal aorta. So also we have some other factors impacting this, which are more related to TAVI design. We have the stiffness of the delivery system. For instance, if you think of the Medtronic device, it has the two spines, which maybe give a lot of stiffness and really make it hard to have a good coaxial alignment when you deal with these anatomies, and so it's not easy really to account for these factors. For sure, the impact of operator experience and learning curve is very high with horizontal aorta. Once you learn to deal with these anatomies with self-expanding devices, which are probably the class of devices which is harder to implant in these anatomies. If you think of balloon expandable, it's really not a significant issue with balloon expandable devices horizontal aorta. So you need to learn how to treat these anatomies, to play with your wire, to push on the delivery system and on the wire when you treat these anatomies with self-expanding devices. Another open question, which I do not have an answer to, is what about extreme horizontal aorta anatomies, which are defined as more than 70 degrees? Those are probably really a subset, which is even harder to treat. And another thing, also, I think I've seen a question in the chat about the cusp overlap technique, if it can help mitigate or not the complexity in these anatomies. So first of all, cusp overlap is recommended only for Medtronic within the class of self-expanding devices, even if there are experiences with Portico and Navitor and with the Accurate Neo. The only true recommendation is for Medtronic. Cusp overlap often, when you have a horizontal aorta, becomes really difficult to reach because it's very caudal, very RAO, even more than usual. So it's these horizontal aorta patients are the ones where you are forced to use a close cusp overlap, but not a true cusp overlap. So I think it's might mitigate, but it's often difficult to reach because of the geometry of the patient and of the angle of the gantry, which would be too extreme to reach in patients like this. I've seen maybe another question in the chat, but I cannot get it anymore. If someone can.
Okay, so I can absolutely. So there's we've answered the question about cusp overlap from Guido. Then we have some questions about practical tips and techniques. So number one, are there any specific tips and tricks for self-expandable implantation in horizontal aorta? And following on, is there any use of the loop snare technique to optimize delivery prosthesis?
Yeah, so definitely there are some tips and tricks. So first of all, what I do not like to do is to use extremely stiff wires, since you need so the Landerquist is not really a good choice. There are some operators using it routinely for Medtronic, especially associated with the cusp overlap, but it's really, since you have to play a lot on the wire, I think one solution to horizontal aorta is really to have a lot of pushing force both on the wire and on the delivery system, so that it really kind of lies in the outer curve of the aorta. The choice of super stiff, extremely stiff wires is both dangerous and not helpful, because usually it maintains a sort of a poor angle, a poor coaxiality angle. So the snare technique, I think personally I've used it a lot for crossing, when I have issues with crossing, maybe valve in valve, or maybe when you have to place a second TAVI in TAVI. In those cases, it can be helpful. I've actually never used it to achieve coaxiality during deployment. And that is because you don't really want to have a snare in your capsule while you are releasing your capsule, because you might, personally, I feel that you have a risk of sort of, entangling the snare onto the device while you are releasing it. So personally, I've not used it for that specific reason, achieving coaxiality in horizontal aorta, but definitely I use it just for valve crossing in cases of issues in valve crossing in complex anatomies.
Great. Pierluigi, I think you raised your hand. Do you have a question? Maybe it was raised by mistake. Okay, so if anybody has any other questions, you can please come online or type them in the chat. In the meantime, Dr. Mark, I'd like to ask you, because a lot of the field is now moving towards, let's say, improving the device technology, second, third generations. Where do you see, in terms of the evolution of device platforms, in order to be able to, will there ever be a one-size-fits-all solution trying to achieve good commissural alignment, lowering higher implantation depths, good coronary access, and also now horizontal aorta? Or is it going to end up being this device for this anatomy in this situation?
I think this is a very general question. My feeling is that you really, the TAVI devices out there are really all are excellent. And I think you could use maybe 80 to 90% irrespective of the anatomy and have really excellent patient results, patient outcomes. So all devices are really good for most anatomies. There are a small subset of anatomies. Horizontal aorta, for instance, could be one, but there are actually many small anatomies, large anatomies, valve in valves, whatever. There are really a ton of patient subsets where maybe a choice is better than the other one. For this specific topic, we have some. We don't have any data comparing directly balloon expandable versus self-expanding, but there are hints into saying that probably, balloon expandable devices are easier to manage in these anatomies, and also some indirect, again, evidence showing that some other devices, the accurate neo, just as you showed the paper, Evelina, is probably, again, easier to manage in these anatomies. So the learning curve is shorter, and probably patient outcomes are more easily reachable and are better in the short term with these kind of devices.
Okay, thank you.
Arif.
Sì,
sorry.
Sì, Fra.
Hi, Evelina. Thank you very much for your clear presentation, and thank you, Dr. De Marco, for joining our discussion. No, I have just a brief comment also to link with the Arif answer. I think that our study, represents a link between the aortic angulation and the device profile. I think that there is much more behind the issues that we usually consider in a TAVI planning, such as leaflets calcification, sinus of valve diameter, leviotic calcification, etc. In my idea, I don't know if you agree with me, the device profile has a crucial role. What I mean with the device profile, I mean the height of the frames that could make the implant easier or not, successful or not. It is known from several studies, as Evelina said before, that the more pronounced the aortoventricular plane is, the more difficult is the alignment and the more paravalvular leaks you leave in your patient. So in my opinion, devices with the low stent frame adapt best in a pronounced aortoventricular plane. And the accurate neo, in this specific case, has a relatively low profile because the distance from the bottom of the valve and the upper crown is relatively low. And for the peculiar releasing concept from the top to down, and the presence of the stabilizing arches could make the implant more stable and precise. So in a patient, for example, in which I will present the coronary access with low to moderate calcification, not severe calcifications, and the huge aortic angle, personally, I will choose a low-profile valve such as Accurate. That's my opinion. I don't know if Dr. De Marco agrees with me.
Well, yeah, I think you made an excellent point, Fra, because really, if you have a higher frame, definitely you are more conditioned into the angle. And so also the tortuosity that you often have after the aortic root in horizontal aorta patient, the aorta kind of turns up. If you have a high frame, that impacts a lot on the canting of the valve when you implant it. So I agree with you. I mean, the Accurate Neo has a relatively short frame because you need to count it up to the, as you said, to the upper crown, and the stabilization arches are soft and bendable, and so they do not kind of force the valve into a bizarre angle. Whereas if you think about Medtronic device, the frame is definitely higher and stiffer, and that forces a more significant angle with implantation. So definitely, I agree with you. Short frame is better for these anatomies.
Great. Okay, so it just comes up to time, so we'll just end the session. So first of all, Francesco Gallo, congratulations for this study and this paper. Very nice, and stimulated a great discussion. Evelina, thank you for amazing presentation and summarizing the whole field of horizontal aorta. And finally, Dr. De Marco, we really appreciated you joined our journal club, sharing your insights and expertise. I hope you enjoyed the discussion with us, and we look forward to having you back.
Thank you so much.
So thank you, everybody. Have a nice Friday and bon weekend.